just like to introduce myself. My name is Karen Stone, and I am a proud St. Joe's employee. My role during the day is Vice President of Human Resources and Facilities, and so a really warm welcome to all of you, and so glad that you could join us tonight. So it brings me great pleasure tonight to say that one of the bright minds is with us and will be talking to you this evening. Dr. Robert Teasell will discuss how his team's research is making a difference in the area of stroke recovery and rehabilitation. Dr. Teasell is the medical director of St. Joseph's Stroke Rehabilitation Program at Parkwood Institute, professor of Physical Medicine and Rehab at Western University, and a clinical scientist at our Lawson Health Research Institute. So please join me in welcoming Dr. Robert Teasell.
All right, can you hear me? Yeah. All right, well, thanks for inviting me. I'm really excited to be here. Couple reasons. It's the first time I've ever had 3 mics on me at once, so if my jacket seems to be weighing me down, there's a reason for it. Second reason is I've been married 37 years, the first time my wife's ever heard me talk. So the nice thing is I'm going to get a lot of good feedback before the night's over with, all right? I don't have to wait till tomorrow. And then finally, I'm really pleased to come and present this talk on stroke rehabilitation, an area that I'm particularly interested in and have done a lot of research in. So let's get started. As you heard, stroke is a common life-altering event, and this is the most I'm going to show you in terms of writing, so don't get too concerned, all right? You're not medical students. I'm not going to treat you like medical students. We're going to try and be a little more entertaining today. But in Canada, 62,000 people, as you heard, suffer a stroke every year, and over 400,000 are living with the consequences of stroke, and we're going to talk a bit about what that means. Stroke survivors have neurological consequences. They have weakness, which is the hallmark feature of stroke, but also deficits in terms of language, which we're going to talk about, swallowing, attention, and vision with high rates of depression. And stroke just doesn't affect patients alone. It also affects families. And it's one of those areas where caregivers themselves experience an increase in physical demands and psychological distress, along with decreases in terms of health quality of life. So it's a big deal. And it's probably 25% of individuals in nursing homes are there because they had a stroke. So it's a very big deal in terms of Canada's healthcare system and the cost towards it. All right, so I thought we'd better start by talking a bit about what a stroke is. I'm not going to give you a lot. This is your main anatomy and what a stroke is for today. But a stroke basically is damage to the brain as a result of an abnormality to the blood circulation. And it can happen in 2 different ways. One is you can block an artery, and as a result, part of the brain is deprived of blood and damage occurs. And the brain's a very sensitive tissue. It can't be without its blood for more than like an hour or so. Less than that, actually, before damage really starts to occur. Or you can burst a blood vessel, which is a less common cause of a stroke, in which case damage occurs because you get bleeding within the brain tissue, which is actually quite soft. And this high-pressure blood can cause quite a bit of damage. And you can see we can image that if this is where you had an obstruction on an artery. And you see in this person's scan, we're looking at a cross-section of their brain here, the skull here and the brain tissue here. You can see this area now is deprived of blood, has suffered a stroke. And because this patient's stroke was on the right side, they're likely going to have some left-sided weakness because that's a frontal stroke. And we'll talk a bit about that right-left division later. All right. So in terms of the consequences of a stroke, because that's really what we deal with in rehab. We deal with what happens after a stroke occurs. I mean, one of the really cool things that's happening in stroke care right now is the neurologists, in particular at University Hospital, have these really cool techniques where they can put blood thinners in and they can break up clots and they can also pull clots out. So that's made a big difference to stroke care. We're seeing a lot less of the bigger strokes that we used to see before. But we still see a lot of strokes, and strokes have a lot of consequences, and it's those consequences that we have to deal with in our rehab program at Parkwood Hospital. So this is the brain here, and people sometimes think of the brain as a black box, but it's not, right? It's not like your computer, all right? The brain consists of a number of highly specialized areas that are highly interconnected. So for instance, here we're looking at the left side of the brain. You have an area that's the movement or motor cortex. That's what moves the left side or the right side of the body. Or we'll have an area called Broca's area, which is where you have speech come out, or your words come out. Or we have an area called Wernicke's area where we understand language. We have an area back here that we'll talk about where you have the visual cortex, where you actually see things. You actually don't see things through your eyes. Your eyes are just a camera. It's the back of the brain where we see things. But the important thing to realize here is that the brain consists of all these super specialized areas. And when you have a stroke is basically when the blood supply gets cut off to part of the brain. The consequences of that stroke are going to depend upon what areas actually get damaged. So it can vary from patient to patient. If they have a stroke over here, they're going to be paralyzed. If they have a stroke back here, they'll develop problems with their vision. So it's a very heterogeneous group of individuals. So I'm going to give you an example, 3 examples of how this can occur. And the hallmark feature of a stroke is paralysis. Paralysis on one side. All right, that's the hallmark feature that we see in most stroke patients. And this is the motor cortex right here. The motor cortex is the area that actually moves the opposite side of the body. All right, now if I have a stroke right there, that stroke probably occurred up there in the upper part of the cortex. And what it does is it damages the cortical spinal tract, which goes all the way through the brain stem, and then just at the top of the bottom of the brain, at the top of the spinal cord, it switches sides and actually supplies the opposite side of the body, which produces this weird paradox, and we'll talk about this over time, is that the right side of the brain controls the left side of the body, and the left side of the brain controls the right side of the body. I have no idea why that is, all right? I did not invent the machine. I'm not responsible for it. I just deal with it, all right? And so you can see this patient, because he's had a stroke up here on the right side of his brain in the cortex area here, will result paralysis here on the left side. So that's one of the consequences of a stroke, is paralysis. Again, probably the main thing that we deal with and where much of the research is focused on is in terms of the motor cortex. Another area that we see, though, is this thing called aphasia, or a disorder of language. All right? And it can occur. There are 2 main areas that look after language in the brain, and I'll explain a bit about language to you as we go through it. There's Broca's area here, which basically looks after the expression of patients that have damage to that front area of the left hemisphere, and remember, it's the left side only, will have difficulty expressing language, either speech or writing. Because it's language, it's not just speech, but it's also writing. All right? So you can't compensate by writing for the difficulties you're having in speech. Understanding of speech takes place in a different area, in Wernicke's area, which is more towards the back. And patients that have a stroke there have trouble understanding language, so they have trouble listening or hearing what's being said to them, or reading. All right? Very, very important. So it's this idea of language, not speech, but this idea of language that the left hemisphere looks after. I'm going to illustrate to you the idea of language with this sort of idea. I'm going to draw for you, I'm not going to draw for you, but I'm going to show you 2 half circles and 5 sticks. All right? So 2 half circles and 5 sticks. Bear with me. It's not the best illustration, but you can see that there's 1 half circle, there's a second half circle, and then we've got 5 sticks. You see that? If you have trouble seeing that, come talk to me afterwards, okay? All right. And yet when you see that, that doesn't mean 2 half circles or 5 sticks, does it? It means something different. In this case, it's a 1/4-ton vehicle with power steering and power brakes. Because I'm a doctor, it's a BMW. All right? When I give this talk to the therapist, it's always a VW. All right? Just so, anyways. And so your ability to make this connection really occurs with your left brain. All right? Very important with the language. Aphasia takes place in the left brain. And it goes 2 ways. So if I see this here, car, and I want to know what does that mean, and I'm able to make the connection between those letters and that associated with that 1/4-ton vehicle with power steering and power brakes, that's done through the Wernicke's area, or the back of the brain, that ability to make that connection, all right, to understand speech, or understand language, understand writing, is done through the back of the left side of the brain, or Wernicke's area. Now, going the other way, the ability to see that and say car or write down car is done by another part of the brain. It's done by what we call Broca's area. Again, I showed you that before. It's more towards the front. Now, what we tend to see a lot in our stroke patients is more of this, damage to this area, where the front part of the M1 of the middle cerebral artery, we tend to see more damage there. And so most of the patients that we see that have aphasia understand quite well what's being said to them, but have trouble expressing the language that they want to get out. All right? But the other thing you need to understand with the left hemisphere, it's not a speech problem, it's a language problem. All right? Very important. All right. And then the final example I want to give you is the idea of visual field deficits. All right? And again, we could give probably 25 different examples of areas of the brain that get damaged. I'm only giving you 3. All right? And you probably think that you do most of your seeing with your eyes. You don't. Your eyes are just a camera. All right? Vision tends to take place at the back of the brain, right here, the visual cortex. That's where it's actually interpreted and where you actually see or understand what you're seeing. All right? And actually, it takes quite a circuitous pathway. You can see here, we're looking at it more looking down on the brain here. You can see the eyes here, and then you have the optic nerve, the optic chiasm ending at the back of the brain. All right, now if I have a stroke here in the occipital area, which is the same as having a stroke here, what that does is that affects the visual field. So that patient that has had a stroke at the back of the brain on the left side, and on the left side over here, their vision goes from this to this. They take out the right side of the field of both eyes. All right? Because you're actually affecting the interpretation of the field, and that red is coming from this side and this side of both eyes. I know it's kind of weird, you know? You think people go blind, they take out one eye. No, you take out both sides. Now, this presents some real challenges with driving. You can imagine, right? Actually, they won't let you drive with this, but it really creates some stresses. But again, it's another example of how having a stroke to the occipital lobe of the brain can cause visual field defects. All right? Just another example of the type of problems that stroke patients can have. So, you know, I think you're getting the picture that with stroke, it's very complicated, right? Because you can get large strokes where you'll get 10 different problems, all right, depending upon what areas are involved. And so if we have a left hemispheric stroke, we can have problems within the left hemisphere, which is right here. We can have problems with right-sided paralysis, aphasia, language we talked about. They tend to get depressed earlier. They can get trouble with complex movements, a condition called apraxia. If they have a right hemispheric stroke, you can get left-sided paralysis, this thing called neglect, where they ignore their left side. We're going to talk a little bit about that later on. They tend to be more impulsive, and they get later problems with depression. And it gets even more scary because we're just talking about the hemispheres. There's a whole brain stem as well, which also becomes involved, which is also part of the brain, which we see a lot of strokes involving the brain stem. And they get a whole new set of problems. Balance and coordination difficulties, particularly because of involvement of the cerebellum or pathways to the cerebellum. Problems with swallowing, problems with speech. This is not a language problem now. This is slurring their speech, more like when you're drunk. All right? Paralysis, because the motor pathways do go through the brainstem, double vision, and vertigo. Again, this idea that stroke's very complicated, all right? These people have very complex neurological difficulties. And so, in order to deal with that, we have things called stroke rehab units, all right? And this is one of the great developments over the last 40 years, is this idea of specialized care. And because their stroke patients are so complicated, people realize they're best managed by an interdisciplinary team. Now, the thing you have to understand about rehab, you know, I'm going to tell you guys, but I'm not going to tell anybody else, all right, is that rehab's mostly therapy, and I'm not a therapist, all right? So I'm kind of like the talking head. You got to think of me that way, all right? Most of it's done through therapists, and we have physiotherapists to deal with the motor side, occupational therapists to deal with their activities of daily living and work on their upper limb, speech-language pathologists. We have dietitians, nurses, recreational therapists, social workers, physicians, psychologists, pharmacists, all working in this interdisciplinary team. And we work very well together, and we work as a team. We actually have 2 teams consisting of all those members looking after stroke alone at Parkwood Hospital. All right, so it's very complex. Studies have shown that stroke care is best delivered within a stroke rehab unit with dedicated specialist therapists who just do stroke all the time. All right, the studies have shown that, so that's what we've developed at Parkwood. We have a 26-bed stroke rehab unit, one of the largest ones in the country, all right, that has a very highly specialized team of people that just do stroke care all day long, all right, so they get very good at it. And so that's what we're well known in the province for the stroke care that we provide. But the important thing to realize here is that it has to be done by a team because we're dealing with such complicated and complex patients. So this is just, again, the backdrop, and I want to, I'm not going to, this is kind of boring, so I'm not going to talk a lot about this, all right, but I'm going to establish it as the key context issue, because this is the foundation on what we do. Rehab is basically a therapist doing one-on-one practicing, or a patient's doing one-on-one practicing with a skilled therapist. This is rehab. You know, repeatedly getting them up walking, repeatedly getting them to use their arm, repeatedly getting them to practice talking. All right, that's rehab. That's its foundation. All right, everything else I talk about in terms of stimulating the brain and priming it and getting it going all has this as its foundation. So I really want to emphasize that, all right? Just so you think we just do some of the other cooler things. There's a lot of this that goes on that's really critical to patients getting better. Now, one of the great findings, I think, over the last 20 years is this idea of brain reorganization and the fact that the brain can recover. I'm not going to spend a lot of time on this. You could do an entire talk on this. It can get very complex. I don't think you want a day of neurophysiology, all right? I think that would not be why you came. I think you want something that's a little more pragmatic. But we know that after a stroke, the brain will attempt to recover. And this is an excellent example. It has to reorganize to facilitate recovery. So bear with me. This is a brain. And this is a patient who's asked to move their right hand. Now, their right hand is controlled by the motor strip, which sits right here on the left side. And so when he's asked to move his right hand, you can see that the left motor area lights up because we can measure activity within the brain using functional MRI. And you can see that the brain lights up, but it's very specific to that area. It's very efficient. Only that area lights up to move the right hand. Now, if I have a patient that's had a stroke in that area, and I ask him to move his right hand, notice what happens. Not just the left side lights up, but the right side lights up too, and all the spaces around it. As the brain tries to reorganize to find different ways, different pathways to move that hand. All right? And this is really brain reorganization at its very simplest. All right? This idea that the brain tries really hard, and we try and help it, to find other ways to move that hand when there's damage to that motor cortex. All right? And so that basically is brain reorganization. Other nearby and connected areas really attempt to regain that lost function. In this case, it's moving that right hand. All right, now there's some rules to brain reorganization, and this comes from the animal data. They do a lot of research with rats, and in this case, they give rats a small stroke. And then they try to rehab. Now, you can't rehab a rat. All right, can you imagine a rat with a walker? Or, you know, the therapist exercising them? All right, it just isn't going to fly. All right, but what they do is they put them in these complex environments where they have lots of toys and lots of other rats to play with. All right, and that's rehab. It's called an enriched environment, and it's a well-known research paradigm. And interestingly, you can put other rats and really give them no stimulation whatsoever. And what we find is that rehab training, or putting patients in these enriched environments, increases brain reorganization, and the rats tend to recover much more. All right, so putting them in a stimulating environment, putting them where they have lots of other things to do, seems to help them to recover. All right, use it or lose it, right? Where there's lack of rehab, or you put them in a box like that, it causes a decline in brain reorganization, and it tends to delay recovery. So they don't do nearly as well. And in the animal studies, and I always, everywhere I talk, I always show this slide. I always say, pay attention to what we're seeing in the animal research. In the animal studies, the key factors which promote recovery include increased activity and a complex stimulating environment. All right, I'll repeat those again. Increased activity and a complex stimulating environment. You know, creating a complex stimulating environment in a hospital is a challenge. All right? And you can imagine if you've ever been to a hospital, they can sometimes. So we really have to work hard at this one, and we're going to show you ways we try to work our way around that. And so some of the principles of rehab and brain reorganization, I'm going to talk about each one of these, and then I'm going to spend a lot of time talking about how we prime the brain for recovery. But I'm going to talk a lot about these ones. And the first one is this idea of intensity of therapy. And that's a really big one. That's one's really become huge in the stroke rehab world. The idea that you have to do enough practice to learn new means of achieving lost functions. The idea that the more we can push people, the better they tend to do. All right? And in these days of cost efficiencies, that's a big deal. Trying to figure out different ways that we can make therapy more intensive. Task-specific training. You know, this might seem silly to people, but the best way to learn to do a task is to do the task. All right? It's the old thing. The best way to learn to play tennis is not to go lift weights. All right? So this idea that you need to be focused on the actual task the individual has to do. One of the really cool ideas, and then we're going to talk about this, is early therapy. This idea that the earlier you can get people into rehab, the better they do. To the point that if you don't get them in early, they don't do as well. It's not like you've delayed their recovery, you've actually hindered their recovery, which is a very interesting concept, which is really, we've taken to heart, certainly at Parkwood, where we're working harder and harder to get people in earlier and earlier. And then finally, I'm going to talk about priming the brain for recovery, which is going to be the majority of my talk. So I'm going to talk about the first three first. So intensity of therapy is a big deal. Research has repeatedly shown the benefits in terms of stroke rehab, in terms of helping stroke rehab patients recover, particularly in terms of the motor recovery, but also in terms of language recovery, repeatedly shown the benefits of high-dose repetitive task practice. So practicing the same thing over and over again seems to help. Animal studies show that if you want to learn a new motor engram, a new way of doing a motor movement, and a lot of our patients have to relearn things, you often have to do hundreds of repetitions. So managing to do those hundreds of repetitions on a rehab floor is a challenge, and it's always been a challenge for us. Realizing that we have to get those 100 of repetitions in has always been a thing that we've been working really hard towards doing. The Canadian Stroke Guidelines, and I just happen to chair those, but anyways, as stated that stroke rehab patients, and this is the standard we've set across Canada, should receive a minimum of 3 hours of direct task-specific therapy 5 days a week. So we've actually set the bar. And interestingly, you know, this comes from the United States, because in the United States, the American Congress has stipulated that all stroke rehab patients under Medicare will get this much therapy. Actually has made it to the level of the US Congress, and actually they're interesting. They've been really successful because if the patient doesn't get that, they don't get paid. So suddenly things are a lot more aggressive in the US, and we're getting there. We're getting there because we're realizing the lessons that they've learned, and we're getting close to this number. When I first started, we were providing about an hour and a half to an hour and 3/4 of direct care per day. We're probably up around 2.5 hours now and getting better and better. It's really become a big focus for us, is trying to improve that intensity, because we know the more intensive therapy we can provide, the more likely patients are going to get better. And to do that, there's been a whole bunch of new ideas coming out, because as we begin to realize we have to provide more intensive therapy, but we don't have a lot more money to do it, we have to figure out other ways to do it. And there are a whole bunch of new ways we're developing to try and improve how we provide therapy. One is, some of the research has shown that if you do group therapy, walking, you can get just as good a result as you can walking people individually. This means that one therapist now can maybe do 4 patients at once and get similar results. It means we can provide a much more intensive environment. Doing simple things like group therapy, and it's certainly well supported by the literature now. Video games. You know, the Nintendo Wii, where you swing your arm, we actually studied it, right? Big study, actually. 4 countries, 12 different centers, we were part of it. And we actually showed that when you put patients with who have stroke and have upper extremity problems, and you have them work on the Nintendo Wii, I don't know if you know this one. I think they play baseball, bowling, and something called Mama Cooking or something. I don't know. It is weird. But anyways, it improves outcomes. It's similar to also spending a comparable amount of time playing board games. So, you know, we've now got our recreational therapists working with our patients as well in order to try and, again, improve the number of movements they're doing, and therefore get up to that 3 hours or more of intensive therapy that really results in a better outcome. And interestingly, this is something that we've introduced in the last 3 to 4 years. We realized we were providing more and more therapy 5 days a week, and then nothing was happening on the weekends, which didn't make a lot of sense. All right, just seemed like a lot of wasted time. Patients were still in the hospital. So now we provide weekend therapy at about half the intensity we would provide during the weekdays. And we're certainly working towards increasing that as well. All right, now task-specific therapy, it might sound a bit silly, but it's a concept that's taken us a while to really get well incorporated into rehabilitation. And it's this idea that, and certainly in animals, brain tends to reorganize much more when one does a task that's meaningful to the animal. All right, and the same thing takes place with people. You know, if people are doing things that are important to them, they're more likely to learn. If they're just doing repetitive movements of things that aren't important to them, they will not learn. All right, this is a hard lesson that you learn, right? Because, you know, oftentimes therapies are designed to put pegs into holes. If that's not meaningful to people, it won't result in learning. All right, more important that you do things that are actually meaningful for people. And so repetition has been shown. Repetition in the absence of skilled motor learning is not enough for brain reorganization to occur. And this is one of the hard lessons that we've learned, but we've learned it quite well, that in rehab we have to be doing things that patients consider to be important if they're going to learn and if we're going to see better recovery. I got a picture here of this lady baking cookies. This is actually being done in her home by one of the therapists in one of our outpatient programs. All right, this is a neat concept that just emerged over the last 15 years, and it came from the animal research, and this is the idea of the earlier the better. And here, animal studies suggested that there's a window, a time window, where the brain is primed for maximal response to rehab therapies. So this is this idea that after they have a stroke, they recover, but that recovery occurs much more quickly if they get intensive therapy very early on. And in this study, they took rats, and it was a study out of Dale Corbett's lab. Dale's in Ottawa now. But where they actually took the rats and they had them either undergo therapy right away or wait a week or 2 weeks and undergo the same amount of therapy. And they found that the rats that underwent the therapy 2 weeks later or a month later, even though they got the same amount of therapy, didn't do nearly as well in terms of their final outcome, indicating that there's something about rehabbing people in that early phase that's critical. All right? And it's been related to actually release of certain chemicals in the brain, like BDNF, which is a brain neurotrophic factor, which seems to promote learning that you also see in early childhood. All right? And you see after a stroke or a brain injury in that very early phase. So it seems to be that earlier the better that people can get therapy, the better they do, such that if you don't provide that therapy early on, they don't do nearly as well, even if you provide an equal amount of therapy later on. All right? So now there's become a lot of impetus, because when I first went into rehab, we'd often wait a month to get someone into rehab. All right? Now we're really hitting them fairly hard at about 3 to 4 days. All right? And into the full rehab by about a week. And that's certainly what our goals are. So this idea of early rehabilitation really helps facilitate how the brain recovers. And so one of the questions that we were asking, and this is a big trial that came out of Julie Bernhardt's lab in Melbourne, Australia, 56-site study, was they wanted to look at, well, when is too early? Or is there a time that's too early? Can we rehab people day one after a stroke? Since if we rehab them earlier, they seem to do better. If we rehab them really early, do they do a lot better? All right? And she did one of the largest trials we've ever seen in rehab, 2,000 patients, where she compared patients to patients that got very early rehabilitation to patients that got later rehabilitation. And interestingly, they found that patients that got rehab, say, day one, first day, and got very intensive therapy for that first 3 to 4 days, actually did worse. All right? So it told us that there's a floor. Really need to give patients about 3 to 4 days to recover after their stroke before we put them through that intensive rehabilitation. So a very important study that just came out. So mobilization in those first few days has to be done very carefully. All right, so we're going back to this again just to remind you that, again, rehab is therapy. Ideally, as I mentioned before, we want it delivered intensively, we want it started early, and we want it focused on tasks that are important to the stroke patient. All right? And again, it involves that one-on-one practicing with a skilled therapist. But now I'm going to talk about some of the things we understand that I think are kind of cool about facilitators and primers of that recovery. Some things that we can do to try and make that even better, all right, that tell us a lot about how the brain works. This is kind of an interesting one. When I first started out in rehab, we were taught this neurodevelopmental technique of therapy where patients would be required to do very specific standardized movements. And for instance, the therapist said, no, we got to get the shoulder working just right under this school of thought, which was very predominant when I first started. We got to get the shoulder moving just right before we allow the elbow to move, because we don't want to develop bad habits. And when the elbow moves well, then we get the wrist to move. All right? It took forever, as you can imagine, right? And it was the standard of care. And then the Australians came up with, and this might seem silly as I describe it, because it does seem silly when I describe it, but the Australians came up with this idea called action observation therapy back around 1990. And what it was is it was pretty simple. They said, well, we're not going to buy into this idea that you got to get the shoulder moving first and then you got to get the elbow moving first and go in that order. We're just going to show them a picture of somebody doing a motor task, like maybe waving or in this hand squeezing his arm into a fist, and then get the patient to mimic it and practice it. And they actually studied it. It's been studied a lot, all right? And they found that patients that did this did a lot better than patients that did just the standardized movements, right? That went right for the gusto, went right for the movement itself, seemed to do better over the long run. Completely changed rehab, right? Because what was happening with this, getting them to just observe what they were seeing in terms of their hand moving, it was helping to prime the brain, all right? It was priming the motor pathways in order to be able to function properly, in order for that patient to recover better. And that's kind of taken a number of weird forms since then that I think are kind of interesting and tell us a lot of how the brain works. This is called mirror therapy. This is a really interesting treatment, in this case for the upper extremity. What we do is we take the patient, in this case, this hand works, and this hand is the paralyzed arm. All right? And what we have her do is we have her perform various movements of the good arm or the unaffected arm and observe what's happening in this side where the affected arm is hidden behind the mirror. So it looks like she's moving the affected arm when she moves the unaffected arm. Do you understand what I'm saying? Now, the weird thing about this is she knows she's looking at a mirror. All right? She knows it. And yet, for some reason, it seems to trick the brain into thinking that the affected arm is moving like the unaffected arm, and these patients make better recovery. And it's been shown in a whole number of studies. The Germans have done a lot of work in this, all right? Even though the person consciously knows that they're doing this, nevertheless, it seems to result in an improvement in that sort of priming that motor pathway. Now, that's weird, all right? And mirror therapy is something that we do utilize. And that's led us to further down into this idea of mental imagery, right? And this has become very popular. This is adapted from the field of sports psychology. And in sports psychology, you know how people sit there and they imagine in their minds how they're going to win the race or do the pole vault or whatever they do. It's big with Olympic athletes, you know, or I imagine when you watch the Toronto play the Boston Bruins and Marchand was sitting there at the national anthem just staring. You know, you can imagine all he could think about was how he's going to win. All right, it's that idea that you're imagining what's going to happen. This idea of imagining how you're going to make the movement. Well, people have done quite a bit of research in this area, where the patient is expected to first mentally practice and rehearse a specific task or series of tasks before they actually execute the movement. So the idea is first they have to think about what they're going to do over and over again and then do it. All right? Mental practice, similar to what we see in sports psychology. And it seems to allow patients to access stored motor plans for executing movements and reinforces them during mental practice. It seems to help prime the brain, seems to get the brain going. It seems to help create those motor pathways that allows them to do better. And when they've compared patients who do mental practice to patients who don't, doing the same movements, the patients who do mental practice do much better. Again, it's that idea of priming the brain to, in fact, work on improvement. Now, this is another interesting concept. We're going to switch around a bit. But whenever you have damage to part of the brain here, this part of the brain becomes weaker. And what happens is this part of the brain is able then to inhibit that part of the brain. It's one of the ways we explain it. I'm going to explain it a little different way. If I get damage to this would be the right hemisphere. That means my left hand isn't going to work as well. All right? In this case, this gentleman's left hand doesn't work so well. So there's a treatment that's come out called Constrain-Induced Movement Therapy. We now have 120 trials on this, randomized controlled trials. It's been one of the most carefully studied areas in rehabilitation in the last 20 years. And what you do is, if this is the weak hand and this is the strong hand, what you do is you simply put a mitt on the strong hand. And now the patient is forced to use the affected hand. Because normally what patients will do is they'll tend not to want to use the injured hand, right? The one that doesn't work so well. They won't want to. But in this guy's case, if he doesn't use it, he starves, right? So it's a very effective treatment. This is constraint-induced movement therapy. You can actually go away to get Birmingham, Alabama, where they have a training program. They do 6 hours of intensive upper extremity training, and they restrain the unaffected arm for at least 90% of your waking hours. So you can imagine if your left hand's not working well, your right hand is, they tie up your right hand. So you can only use your left hand. All right? Really cool treatment. All right? I could tell you right now, my therapists don't like it. All right? But we use it all the time. Patients don't really like it that much either. All right? But it's very useful. It seems their spouses don't mind it, though, which is kind of never quite figured that one out. But really strong evidence that it works, and it helps to overcome that inhibition of the stronger side. So a very important treatment in terms of stroke rehabilitation. But we can do it other ways, because there are a lot of other cool ways that we can begin to look at trying to change things. This is called brain stimulation. Brain stimulation involves primarily non-invasive motor cortex stimulation. And basically, we're stimulating the brain using either a magnet or electricity. All right? And there's two types. One is repetitive transcranial magnetic stimulation, or RTMS, that we actually have a machine at Parkwood that we use for treating depression as well. It treats a lot of things, which is interesting. And the other one's transcranial direct current stimulation. I'm going to talk about both. So this is the magnet, and this is the electrical stimulation. And what it does is it involves use of a coil that produces a magnetic field that passes through the skull to the cerebral cortex. If you give low-frequency stimulation, you tend to inhibit the cortex on that side. So you may give low stimulation, low-frequency stimulation to the side that's stronger, because you want to inhibit it, right? And then you can give high-frequency stimulation and stimulate the brain to the side that's weaker. All right, the side that's been damaged with the stroke and isn't functioning as well. And it has been shown to actually improve motor recovery, just doing that cortical stimulation. So that's one of the things that we're going to be looking for in the next little while, because we're starting to play around with the idea of using this at Parkwood, because it's become a really cool tool that a lot of people are starting to use. It's become very popular in Asia, and something that we certainly want to start to use at Parkwood, because we've been playing around with the idea. The other interesting one is this idea of transcranial direct current stimulation. Similar idea, but this applies a electrical current, low amplitude, to the person's skull. You can actually now buy these commercially. So some of my patients have gone out and bought them to stimulate. And basically, if you do anodal stimulation, it increases cortical stimulation. The cathode decreases cortical stimulation. And again, where you place it, you can actually begin to influence motor recovery. And again, numerous studies have shown this can be useful in terms of facilitating motor recovery, ways we can, again, improve how the brain recovers. This is a little different concept. This is the concept of functional electrical stimulation. This is where we use electrical stimulus of muscles, and this is becoming used a lot more at the peripherally, more in the actual leg or the arm itself. All right? And this is really cool. One of the problems we have with stroke patients is they often have weak ankle dorsiflexion, so they tend to drop their foot, and when they go to walk, they catch it, right? They can't swing it through. It's a big problem for them when they go to walk. So we've developed this commercial tool. It's called a peroneal nerve stimulator, and what it does is the stimulator goes on the leg, the affected leg, and it stimulates the peroneal nerve, which causes the foot to come up. The ankle comes up into dorsiflexion, all right? Pulls it up so it can swing through, all right? It also has, and this makes it really elegant, it has this little stimulator or a little sensor that sits underneath the heel. All right? So what happens is the patient walks, and when his heel hits the ground, it turns the stimulator off. So the stimulator stops pulling the foot up, because remember the foot's weak because it's had a stroke. And the foot goes flat, flat, and then as he begins to walk and starts to prepare for his swing through, it pulls the heel up. The stimulator, the sensor goes on when the heel comes off, and it results in stimulation of the ankle dorsiflexion, which pulls it up and allows the foot to swing through until they hit the foot again, and it turns it off. Foot goes down, foot goes up, so the heel goes up, the stimulator goes on again, they can swing through, and it allows them to walk like a normal person. It's really cool. All right? Costs a couple $1,000, but really cool if you could afford it. And we have a bunch of them at Parkwood that we let patients play with in the outpatient clinic, and if they like it, they can purchase it themselves. And that actually came through donations as well. And this is a similar one. This one costs $6,000, but it's a similar type stimulator that uses the upper extremity. It goes on like a sleeve, and you can see it stimulates the muscle so that it can grasp and release, depending on how he manipulates the electrical current to get the muscles to contract. And here you can see he's grasping a bottle so he can lift it off. And again, this is a way of getting the muscles to react normally, get the arm and leg to react normally. And it's interestingly, if you use this with patients, it means they can begin to practice like they would do things normally, and it actually helps facilitate, again, recovery. It actually teaches the brain what the right way to do things is. So it becomes very, very important in terms of their neural recovery. All right, this is another cool thing. We got one of these at Parkwood. This is the Locomat, or similar. What it is it's a patient suspended on a treadmill over a treadmill here, and then he has these legs here, which are electrical mechanical legs, which are robotic legs, that walk him. So he may not be able to stand, but the suspension, the legs will walk him in a normal walking pattern. This has not been shown to be all that useful for moderate and mild strokes, but it's very useful for more severe strokes. Because what it does is it allows them to actually practice walking, and early on it can help to facilitate patients recovering more quickly. So this is a really cool tool, very expensive, but beginning to be used more and more for stroke. This is the Exoskeleton. We also have one of these at Parkwood. They're pretty cool. All right, this is an exoskeleton that you can put the patient inside it. There's a power pack at the back, and basically what this exoskeleton does is it moves the patient's legs so they can actually walk, all right, with a therapist controlling things at the back. It requires a therapist to do the walking, but it's thought to be really effective for early, more severe strokes. And we actually have a big randomized controlled trial that we're doing right now with University of British Columbia in Calgary, where Parkwood's one of the sites that's looking at the benefit of this device for more severe strokes. These are the kind of things they're developing for the US Army to produce the super soldiers. This technology is still very clumsy at this stage, but this is going to be really hot. All right, we're seeing it becoming more and more smaller, more and more effective, more and more sensory devices into it. And so this is really the future for a lot of stroke rehabilitation. This idea of the exoskeleton and teaching patients how to walk normally using these robotic devices. This is something a little different. You remember I talked about aphasia, where you have difficulty with language? One of the cool things that we work on is a thing called melodic intonation therapy, where you have really two major components with music. We actually use music to teach patients how to talk better. Because one thing about music you need to understand is it's largely run by the right hemisphere, whereas language is run by the left hemisphere. Yet they have a lot of neural pathways that they control together. So you can actually get patients to learn to talk better by teaching them to sing. And so that's actually a treatment. It's called melodic intonation therapy. So you get them to sing. Singing's interesting. It reduces the rate at which words are articulated, and it allows them to string out the words better to enhance fluency. So it can be very effective in terms of, particularly for milder aphasic patients, in helping them to better speak. And then the rhythmic tapping while the words are done and eventually phrases are repeated may engage that right hemisphere, sensory-motor network, and improve verbal production by bringing the right hemisphere into play in terms of language. So really cool, using language then to bring the other half of the brain into play to help a patient in terms of their recovery from their aphasia. And then finally, this is a concept of left-sided neglect. I'm not going to spend too much time on it. I know I'm getting near the end of my time. But this is what happens when, we talked about aphasia, language problems occur when you affect the left side of the brain. When you affect the right side of the brain, you get something completely different. You get this problem called neglect. Now, this just shows you a patient who has severe left-sided neglect because of his right hemispheric stroke. He has trouble paying attention to one side. And you can see this is after he's completed his meal. He doesn't really pay any attention to what's happening on the left side. Only pays attention to the right side. Here he's asked to draw a clock. Here he's asked to draw the middle of the line. Here he's asked to draw the middle of multiple lines. He ignores these altogether. This happens because what happens is normally the right side of the brain controls the visual field on both sides, right and left side. But the left side of the brain only controls the visual field on the right side. So paying attention to the right side. I always think of it because the left side's too busy with language. It can only look after half of the brain, all right, half of the field. And so what happens if I have a stroke on the left side, which causes my language problems, the right side can compensate. But if I have a stroke on the right side, the left side can't compensate, so I don't tend to pay attention to the left side. All right? This is a big problem for us, and we see a lot of these patients. And one of the things we do to try and improve this, and we also do this with patients that have field cuts, is we use prisms. So we apply these Fresnel Prisms to their glasses. It's quite a fascinating thing. And what it does is it shifts the visual field over. You can only shift it about 10 degrees or else the brain gets too confused, but it's really been shown to improve neglect in these patients. Just one of the little tricks we do to try and trick the brain into recovering more quickly. All right, and then I'm just coming to the end now. This is a big trial that we're working on now. This is an interesting one that's got a lot of people's attention. This is a French trial initially, and 9 sites, and what they did is they gave Prozac. You know what Prozac is, eh? Antidepressant. They gave Prozac to patients at day 10 for 3 months that had a stroke, and they found that patients that got Prozac 3 months later did much better. They made a better motor recovery. So this has been causing a huge fury. And the mechanism isn't certain. We think it's because it actually plays around with chemicals in the brain that help promote neurorecovery, BDNF in particular. And we actually are part of a big trial here, a big $3 million trial, 8 centers, which is looking at applying Prozac, but we're not applying it at day 10, we're applying it at 3 months, right, to see whether it actually does continue to facilitate motor recovery and keep that ability for a patient to recover after a stroke much longer. And that study is underway currently. We're now part of it. It's called the FLOW study, and it's centered out of Ottawa and Toronto. And then I'm finally going to finish with this idea of stroke rehab at home, which I think is a really important concept that we're really interested in. We are probably the world experts in how to manage patients at home in terms of stroke rehab. I don't think there's anybody that has the kind of programs that we have here in southwestern Ontario. We actually have 4 specialized multidisciplinary stroke rehab teams. I call them SWAT teams, all right, because that's what they are. They're SWAT teams that actually go into patients' homes. And we have them in Owen Sound. We have a whole team there. We have a team in Seaforth. I once was in PEI lecturing on this, and I says, anybody know Seaforth at all? And there were like 3 people in the front row at a Prince Edward Island conference that knew where Seaforth was. But we have a full team at Seaforth, and we have 2 teams in London. And they actually go into the patient's homes. It's a really cool program. We have data now on about 5,000 patients. We published a lot on it. It's a full team, physios, occupational therapists, speech-language pathologists. Sometimes we won't even admit patients now to the inpatient rehab unit. We just send the milder strokes straight home and manage them with these teams, all right, rather than actually bring them to the inpatient rehab unit. It's all centered out of Parkwood. And it's an interesting one. We've shown that we've compared them to patients who are still getting hospital-based rehab, because we also have an outpatient program at Parkwood. But we find that patients that actually get their outpatient therapy at home seem to do better. It's really interesting. We're just starting to notice this, but patients that go home seem to do better. They seem to make more gains. And I don't know why that is, but I think outpatient therapy in the home allows for practicing skills in a real-life setting, which may account for greater gains. And I'm a big believer that one of the fastest ways that we can improve patients in terms of getting their motor or getting their the brain to recover is to get them home. Because home is nowhere more stimulating and interesting for patients than going home. And that's it.
Ladies and gentlemen, please join me in thanking Dr. Bob Teasell. Good evening, everyone. My name is Michelle Campbell. I'm president of St. Joseph's Healthcare Foundation. My brain is working overtime right now because I am flashing back to more than 20 years ago when Dr. Teasell first joined our team at Parkwood. And the innovation that we've seen over the last 2 decades that has happened as a result of Dr. Teasell and the entire rehab team at Parkwood is really quite exceptional. And I think as I watched your presentation, one of the things that I'm reflecting on is the sheer application of technology. And we're learning so much more about how the brain operates and how to get function back to people so they can get back to life. So I want to thank you, Dr. Teasell, for joining our DocTalks series. Fascinating, lots to think about. I want to thank CIBC for hosting our DocTalks, sponsoring our DocTalks series. Our next one that is coming up is on Thursday, July 11th. Dr. Harold Kim is going to be talking about the subject of food allergies. Thank you for joining us tonight. I want to thank you also for all of your support. A lot of the technology that you saw in Dr. Teasell's presentation, a lot of the research you heard about is only enabled because of donor support through the foundation, and we've seen a lot of that innovation in rehab as a result of philanthropy in our community. Many people that come to DocTalks are responsible for that, so I want to thank you for that support. Please enjoy your evening, and we'll see you at the next DocTalks.